Hello, my name is Tom, and I'm here to talk about peptic ulcers. In this video, I will be talking about peptic ulcers, starting with a bit of background knowledge on the stomach and its structure, the protective and aggressive factors in the stomach, and then explain what peptic ulcers are, explain the pathophysiology in the context of the two main causes of peptic ulcers, how to recognize if the patient has peptic ulcers, what complications they can have with that, and how to treat them out of hospital. So stomach lining physiology. So the main reason for the stomach is to produce chyme, which is like from our food. It has four layers: the mucosal layer, the submucosal layer, and the muscularis, and the serosa. So basically, the mucosal layer is there to help maintain the epithelial layer, which has a pH of 7, but the lumen of the stomach has a pH of around 2. So we're just trying to which is produced by periosteal cells in the gastric pits, as you can see in the image over there. This looks confusing, but I'll try and break down what's going on. So basically, our mucosal layer needs to maintain the mucus and epithelial layer so that the stomach acid doesn't get through. The mucosal layer does this by a long list of mechanisms that keep the protective layer going. Here are the ones that I think are most relevant to peptic ulcers. First off, periosteal cells also produce bicarbonate ions, which are secreted into the mucus layer to help neutralize any penetrating hydrogen ions in the mucus layer, so the acid. If the mucus layer fails, the epithelium second in line to make sure the acid doesn't break through. So that has a number of mechanisms. So is able to produce heat shock proteins, which help them survive in higher temperatures and acidic conditions. They have tight junctions, so acid can't quite break through them. The hydrophobic, which repels acid as well, and they continuously renew themselves, so they have always being replaced. So I've got some stuff highlighted. So I've got the mucus layer. So prostaglandins are fatty acids produced in the mucosa layer. And that just helps, it stimulates mucus production and protects the mucosal cells. So produced by mucin granules. So the mucin granules are the cells that produce mucin, which is like the main body of the mucus layer that protects the epithelial layer. That'll be important later. And we also have phospholipids. So there's a thin layer of phospholipids on the outside of the mucus layer, which, as I've quoted here, it has the greatest effect on slowing down the capacity of hydrogen ions penetrating the mucus layer. So it's really important for protecting the mucus layer, which will be important later when talking about the reasons for peptic ulcers. And so what are peptic ulcers? They're holes in the stomach wall caused by acid penetrating the mucus layer and the epithelial layer, so getting to that submucosal layer, which can cause bleeding, and even sometimes into the muscularis, which would cause a lot more pain. So it happens in the stomach and the duodenum, so the duodenum being the end of the stomach where it just gets flushed out. And in some cases, they can become perforated. The most common cause of peptic ulcer is the Helicobacter pylori. It's not super common in Australia, so it's 15% overall in Australia. It's 50% overall in the world, so it's quite common across the world, just not in Australia. It is prevalent in Aboriginal rural communities, so it can be up to 6% in Aboriginal communities, which can be relevant to paramedic practice if you're going into an Aboriginal community that could be in your mind. Helicobacter pylori causes peptic ulcers by impairing the mucin lipid network in the mucus layer. So that those phospholipids I talked about before, they disrupt those and they break that that shield, which then weakens the mucus layer and acid can get through. And second to that, when the bacteria infect the epithelium, it causes inflammation and corrosion, furthermore furthering the ulceration of the area. The second most common cause is long-term use of NSAIDs. So NSAIDs are a bit more complicated. So as we talked about prostaglandins before, which are very important in maintaining the mucus layer, NSAIDs inhibit cyclooxygenase, which is a really important enzyme that produces prostaglandin fatty acids. So when they're inhibited, it can lead to reduction in protective factors and damaging the mucosal layer, ending up with mucosal injury and then gastric ulcers. So what kind of symptoms and history would we expect from a patient with peptic ulcers? So I decided to do a dollar here. So descriptors. Mainly you get gnawing pain and burning pain. The onset, so pain worsens after eating. So when there's a gastric tide, so there's higher gastric levels in your stomach, it will hurt more, and that's in the gastric ulcer. So and on the other hand, pain can improve after eating if it's a duodenal ulcer. The location generally epigastric region, so your upper, just below your rib cage. Other signs and symptoms: nausea, vomiting, blood and stool, guarding of the epigastric area. Some patients report back pain, so radiating to the back, and sometimes there's relief with antacid medication. So, what kind of history would we expect from this patient? So, medical history of peptic ulcers before, perhaps, long-term use of NSAIDs, including aspirin, and potentially even Crohn's disease. Social history: they've travelled to the third world country recently, so it's more H. pylori or Helicobacter pylori is more prevalent in third world countries. Alcohol consumption can also cause peptic ulcers, stress, and smoking as well, risk factors for peptic ulcers. So a really bad complication that can occur is perforation of an ulcer. So that's just the full depth of the ulcer right into the peritoneal layer and through that, and then you can get gastric content into the abdominal space, which is really not good. So you can get septic shock, SIRS, so systemic inflammatory response syndrome, severe stomach pain, MODS, so multi-organ dysfunction syndrome, and is very potentially fatal. So these patients become septic very quickly because they're just all their gastric contents is leaking out into their abdominal cavity, causing infection. Can be a really quick onset of sepsis. So I've put the slide here because I think it's really important to note that the symptoms for peptic ulcers are the same as a lot of other serious complications, like acute coronary disease syndrome, a triple A, foreign body ingestion, esophagitis, duodenitis, hepatitis, diverticulitis. So just all those other diseases very closely look like peptic ulcers. So you should never, especially with the AAA, just always assume the worst with these patients rather than it could be peptic ulcer. So it'll treat them like a peptic ulcer, but it could very well be a AAA. So out of hospital care, so these patients need analgesia and pain relief. So fentanyl, methoxyflurane, and avoiding NSAIDs such as ibuprofen because they can worsen the symptoms of those peptic ulcers. A thorough history and abdominal evaluation, transport to hospital. As spoken before, antacids can relieve symptoms of peptic ulcers. So if that's reported to relieve pain, then self-administration of antacids is definitely helpful. If it's a suspected perforation, so going full-blown sepsis, going tachycardia, hypotension, fluid restart, and antibiotics if transport is over 1 hour. Cool. Thank you for watching.